We have a 30-year-old woman who sustains a tibial fracture in a motor vehicle accident. Post-op, she develops a DVT and starts on apixaban. She asks if she has a genetic disorder that she might pass on to her future children. And you consider sending a workup for hypercoagulable disorders. Which of the following is the best next step? So, can you guys see the poll everywhere? No, okay, sorry, try that again. Okay, so here we are, and 100% of our respondents have chosen choice C. So that's great. Okay, now let's bring us back, sorry for the technical issues, to our slide. So you're all correct. You should not test unless you have a future unprovoked clot. Now let's talk about what is that workup. So a hypercoagulable disorder, what do we mean when we say this? So there's both inherited and acquired hypercoagulable disorders. In the inherited category, we think about things like gene mutations and then protein CS and antithrombin deficiencies. And then the acquired is the more of the things that we tend to see more commonly. So at the bottom are the major risk factors that we often see in the hospital, and then other rarer things like antiphospholipid syndrome, things like polycythemia vera or essential thrombocythemia, nephrotic syndrome, and PNH. There's a whole slew of acquired issues, but when we talk about an inherited workup,
only 5 minutes, so sorry, it's annoying.
The stuff on the left is what we're talking about. Okay, so a thrombophilia workup, what does that actually mean? So if you're looking for inherited or acquired causes, this is kind of the basic workup that most people are talking about. So checking for these mutations, looking at a protein CS and antithrombin level, and then the antiphospholipid antibodies that you could send. But not all these studies can be sent at any time. So one thing to know is that during an acute phase of the clot, your levels of protein C, S, and antithrombin are actually going to be low or suppressed. So it's not reliable to send this workup during an acute thrombosis event. The other thing to know is that many medications that you're going to put the patient on for their clot can interfere with the assay of these tests. So warfarin in particular will affect your protein C and S levels during initiation. Certain DOACs can actually affect the assay for these labs, and checking them can be done, but it's much more complicated. And then same with the lupus anticoagulant is actually affected by many of our anticoagulants as well. So you can't really test during anticoagulation, and you shouldn't test after a clot. So then it brings up, should you be testing? So in 2013, the American Society of Hematology actually put out a choosing wisely statement that said, do not test for thrombophilia in an adult patient with VTE if you have a major transient risk factor like surgery, trauma, or immobility. So you should not be sending off this workup essentially if it is a provoked clot. So are there any guidelines to guide when you should do this? It turns out there are not. But there is a wonderful review from the NEJM in 2017 at the bottom of the slide that tells you when you should consider doing an inherited thrombophilia workup. So some of the risk factors are if your patient has a clot at a young age, so under age 45, and it's otherwise unprovoked. If they have multiple clots that are unprovoked. If they have a family member, like a first-degree relative who also had a clot at a young age. And then thinking about clots in unusual spots. So if you have a cerebral vein clot, this is actually concerning for something like paroxysmal nocturnal hemoglobinuria, strangely. And then a clot in your splanchnic vessels, like Budd-Chiari syndrome, should prompt you to think about diagnoses like polycythemia vera, which is more common with that. And then lastly, if you have arterial clots or repeat fetal loss at greater than 10 weeks, then you should think about antiphospholipid syndrome and do the workup for that. So outside of these risk factors, you really should not be doing an inherited thrombophilia workup. The other thing to know is that, as we've mentioned, testing at certain times is very difficult to do. So don't test at the time of the acute clot. Don't test during anticoagulation, and then don't test, as we spoke about, when there is a major risk factor present. So in summary, you should first assess if there are some of those major risk factors for an inherited thrombophilia or another disorder. And then ask yourself, is it actually going to change management? So if your patient is going to be on lifelong anticoagulation because they've now had 2 unprovoked clots regardless, then knowing whether they have some kind of disorder does not really change and it's not worth testing for. On the other hand, if your patient has multiple family members with clots or is, wants to know their genetic status for family planning purposes, it makes sense to test in that case. So if all of those, then send workup. Again, avoid testing at the time of an acute clot if you're on anticoagulation, and then if the clot is provoked. And then just a quick summary of all of the risk factors that should prompt a workup for an inherited thrombophilia. Questions or comments?